Welcome to AHLA's annual Top 10 series, where we discuss the major health law trends and developments of 2026. Learn more about AHLA at americanhealthlaw.org.
Thank you for joining our podcast today. I'm Anna Lozoya, a vice chair with the in-house Counsel practice group. And joining me today is Miranda Franco, a senior policy advisor with Holland Knight based out of DC. And today's podcast is based on her Health Law Connections article entitled Redefining Public Health Policy. Miranda, so based on your article, you've written that the 2026 represents a turning point for the U.S. public health policy. Stepping back, what makes this moment different from prior reform cycles, and what do you see as the defining forces reshaping public health right now?
Thanks, Anna, and a pleasure to be with you this morning. So it's a pretty big question, right? So first, federal public health institutions have undergone an unusually deep and rapid transformation in the last year. So we've seen changes to agency staffing, organization, and funding that have really altered some of the core functions, from disease surveillance to research oversight, and just how all of these things are carried out. So I think unlike past reform efforts that focused on expanding or refining programs, this past year really reflected a rethinking of the federal government's role in public health capacity itself, and certainly with some long-term implications. The other thing I would underscore is that health policy, I think we're seeing increasingly shaped by the courts, if not more than by Congress. And so last year, we saw some major Supreme Court decisions that clarified some issues, such as preventive services coverage, while opening new avenues for some state-level divergence in areas, particularly in the Medicaid arena, for example. And then there's ongoing litigation over federal authority and funding decisions and agency actions that has made health policy a bit more fragmented and certainly less predictable than in prior reform eras. And then lastly, and I touched briefly about this in the article that I crafted, but as we all know, Congress passed H.R. 1, which has significant implications for coverage and access and state budgets. And then at the same time, Congress has not yet or will not extend the enhanced premium tax credits for ACA coverage. So those are pretty significant elements that are certainly have impacted the last year, but will have these ripple implications moving forward. So for 2026, all of this is unfolding in terms of implementation in the shadow of the 2026 midterm elections. So there's some heightened political sensitivity around healthcare affordability, Medicaid, and public health spending. So I think we're in for another head-spinning year, certainly.
I definitely agree. It's been head spinning, I think, for everyone in healthcare. Like you said, very fragmented, very unpredictable. The administration has kept all of us on our toes. Along those lines, the administration's Make America Healthy Again agenda places a strong emphasis on chronic disease prevention and long-term management. How is the CMS Innovation Center being used as a vehicle to advance that agenda?
Sure, it's a great question. So the current administration, I think, is really repositioning the Innovation Center. We've seen several models be removed. We've seen several models be revamped and a litany of new models introduced. So I think this CMI is really focused on balancing sort of low-risk models that deliver predictable near-term savings with longer horizon initiatives. Many of those sort of follow the MAHA agenda, so focused on chronic care prevention and management that require incubation, but have potential to drive system-level change. So last year, as I was noting, we saw a sharp acceleration in CMI's launch of new value-based care models. I think they'll be pivotal as stakeholders decide this year which models to pursue, assess their impacts, and then identify some key markets and partners.
How does Access and Elevate signaling shifted towards longitudinal prevention-oriented care rather than episodic interventions? What, in your opinion, is fundamentally different how CMMI is approaching chronic conditions in this new generation of models?
Sure. So I think we're still learning a lot about those models in real time and still awaiting some details. But Access, for example, is a 10-year voluntary model structured around outcome-aligned payments for technology-supported care options. that prevent and manage chronic disease in conditions that represent a pretty large share of the Medicare population. And then Elevate, also voluntary, is a $100 million initiative that funds up to 30 pilot projects focusing on lifestyle, behavioral, nutritional interventions to prevent chronic diseases. I think the Elevate's charge is even more explicit in that it aims to address lifestyle choices and behaviors to chronic disease prevention and long-term cost. So I think what we're seeing with some of these models is, instead of what we've historically done under the Innovation Center, which is paying mainly for episodic treatment after deterioration, these models are designed to pay for sustained engagement, function, and prevention, especially when digital tools or team-based supports can help keep people stable.
Early interventions are central to chronic disease management, such as digital therapeutics. They fall outside of traditional Medicare benefit categories. How is CMMI using its model authority to test these approaches without prematurely locking in permanent coverage decisions?
Yeah, no, great question. I think CMI is essentially creating a controlled testing lane, right? That is the whole purpose of the Innovation Center. And so in this instance, instead of declaring a new nationwide benefit, we can look at access again. So access is a good example of that approach. It's designed to expand access to technology-supported care options through model payment structures while still operating as a demonstration with evaluation criteria. So, for example, there are no CPT codes to determine payment under this model. Payments are on a per patient revenue line as long as the provider meets outcome targets at the population level. So in other words, CMMI can ask, does this improve outcomes and lower our total cost in the real world before anything becomes a permanent benefit?
Also touched upon drug pricing. This renewed attention to drug pricing, right, includes a new wave of most favored nation proposals and the next phase of IRA negotiations, many of which affect drugs used to manage chronic disease. How do these pricing reforms impact patients?
Yeah, I think there's a lot of talk about how to diminish list prices and not a lot of discussion around the patient piece and how this impacts patients. So just to back up for a second, on MFN style approaches, which pegs US prices to the lowest level paid by comparable countries, I would say this has really, to date, sort of functioned like retail deal making rather than durable wholesale policy. So it's been very narrow. It's been manufacturer by manufacturer, and it creates leverage for negotiated arrangements that can get manufacturers through the next few years. But it doesn't necessarily sort of rewrite the underlying incentives the way that broad rulemaking or legislation would, or the way that IRA, Medicare price drug negotiation has. I think for patients, specifically on the impact for, if you look at the Medicare Part B drugs out-of-pocket exposure, it's often buffered by supplemental coverage, right? So it's not about the list price, it's about what is the patient actually paying. And so if you look at Avalier, for example, they did an analysis on the proposed GLOBE methodology. And so the GLOBE models is, again, focused on Part B, found that only about 0.3% of sampled fee-for-service beneficiaries would be directly affected by changes in out-of-pocket liability. And that's largely because most users of eligible drugs have some form of supplemental coverage that offsets the 20% coinsurance. So even when a policy reduces program spending, it may produce limited direct out-of-pocket savings for most beneficiaries under the model as designed. That's not to say the model is irrelevant, though it can't undo the basic economics of the global drug marketplace. And I think, in my humble opinion, it's easily gamed. But if your main goal is lowering what patients pay at the pharmacy counter, then I don't think these MFN style models by themselves may move the ball as much as people assume.
Miranda, I think those are valid points. They're two different agendas and goals in terms of negotiating the pricing there. Since the article was written, vaccine policy has continued to evolve. The Trump administration unilaterally reduced the number of recommended pediatric vaccines. How should policymakers, providers, and payers interpret this shift? And what are the potential downstream implications for coverage, reimbursement, and public health infrastructure?
Yeah, and just to sort of recap, because as we were saying in the beginning, there has been such, as I was preparing for this, I forgot about so many of the things that have transpired in the last 12 months because there's just been such a deluge. So just to recap, in 2025, HHS made some pretty significant changes to federal vaccine policy and governance. So the secretary, as I'm sure everyone recalls, replaced the full membership of CDC's advisory committee on immunization practices. And so they update on national vaccine schedule, and the reconstituted committee proposed revisions to several vaccine use recommendations, and some of those are currently being challenged in court. And then separately, HHS removed certain immunization measures from the Medicaid state reporting requirements and began winding down many mRNA research projects. And so that's just touching on a few of the changes. But I think what I wrote about and what's transpired and sort of been updated since I wrote my article is regarding some of the most recent action on CDC changes to pediatric vaccines. So children under CDC recommendations would be routinely vaccinated for about 11 diseases rather than the prior 17. And so we've already seen just in the last few weeks, major medical organizations respond by maintaining their own broader schedules. So the American Academy of Pediatrics, for example, published a 2026 schedule continuing to recommend routine immunization against diseases that the CDC updated, moving away from, again, what they recommended universally. So, and it's interesting, just as someone with a small child, I think I've seen my pediatrician in email come out and sort of emphasize that they're not changing their vaccine schedule. So the messaging of this is something that we're seeing really ramp up. But I would say with all of that in mind, downstream, there are three and I'm sure there are many more, but just to narrow it for the purposes of this podcast, things to watch. So I think the coverage variability could be impacted by this. So if payers anchor their coverage to federal schedules, you could see more prior authorization, more medical necessity disputes, or more differences across plans, unless states, and this was sort of touched on in my article, sort of the variation between state approach and federal approach, or purchasers hold the line with their own requirements. The second piece here is around sort of the provider workflow. I think more shared decision-making documentation is going to have to transpire, more time counseling, and potentially more friction for physicians to get reimbursed cleanly. And then just public health capacity. When guidance diverges, confidence and uptake can drop. And then you're relying more on sort of outbreak response and catch-up campaigns, and then having to create a safety net infrastructure. So those are the things I think in the public health community we will all be watching for.
Yeah, and recently we've seen, outbreaks of childhood diseases that we thought were eradicated, at least when I was growing up,
Sure.
as recently throughout the country. So, in closing, if you were advising a health system or organization deciding where to invest time and resources right now, what is the one strategic bet you would make based on where the Innovation Center and public health policy are headed in 2026?
Yeah, I think for CMMI, they unveiled a new strategic direction, and I think it makes it pretty clear that engagement and data and fiscal accountability is sort of the new center of gravity. And so I think health systems and invest now in scalable patient engagement infrastructure, not just tools, but workflows that use behavioral science, sort of defaults and feedback loops will be positioned for some of the models that come next. And I think concretely that means embedding behavioral design into care pathways, not treating sort of engagement as a patient afterthought. So I think there's a lot of focus on patient adherence, certainly. And then pairing that, as we were talking about earlier, just pairing that with deployable digital tools. I think there's a huge desire by this administration to look at remote monitoring, AI-enabled clinical decision support, asynchronous care that's done through digital tech that can sort of flex across the fee schedule or ACOs and future CMMI models. And then, this CMMI is moving, as I was mentioning, sort of at a DARPA-like pace. They're going to move much quicker than I think we've historically seen, but obviously lowering cost is always top of mind. And so designing everything with sort of an actuarial or taxpayer scrutiny in mind. So showing real utilization shifts, not just some of those other elements I was mentioning earlier. So in other words, sort of build engagement that changes behavior, supported by tech that can be reimbursed or absorbed into value-based models is some of the things I'd be looking at from a regulatory perspective.
Well, thank you, Miranda, for joining us with the podcast.
Thank you so much.